and see us, hear us, just making a test for the remaining 3 minutes. The audience can share in the chat now. Mr. Mohab,
هم بيردوا يا دكتور ايمن.
yes, okay. Okay. Yeah, so we have some attendees now. Dr. Fatma from Bahrain, how are you? You can see it here clearly. Yeah, good news.
I think Dr. Fatma was in the APUS, the WebUS webinar recently, I believe.
Welcome, welcome everyone.
Welcome Dr. Stephen Glasser to our meeting.
Yeah, that's great.
Welcome everybody.
Fatma just answered.
We have Dr. Nihal Shakhanqiri also in the audience. Welcome, Dr. Nihal.
We'd like to welcome Dr. Ada
Yeah,
Baidi
too many audience. They have
and the
the
attendees.
number of audience. Good luck. Thank you, Dr. Nihal. Okay. So how many minutes we have to start?
2 minutes.
2 minutes. Okay.
I would like to welcome Dr. Muhammad Al-Saida to the meeting. Professor Dr. Muhammad Al-Saida.
You can see a lot of famous names, a lot of our friends. That's very interesting. I wish this webinar, which will start in a couple of minutes, will be interesting for all of you. Yeah, I'm running with the names. Many friends are there from many parts of the world.
دكتور ايمن ودكتوره هبه، احنا ممكن لو حابين ندخل حد من الاتندي يكومنت او يقول حاجه، دي حاجه بايدينا، ندخله يكومنت وبعد كده يرجع للاتندي تاني.
هايل، ده هايل طبعا.
Anyone ask?
هايل.
More than welcome.
احنا الشات شايفين الشات صحيح؟
Yes. Can start now.
Yeah, okay, let's start. Dr. Tard.
Yes, please. Good evening, everybody, and welcome to the Memorial Institute Kids Eye Center first online Grand Island. I would like to welcome everybody and thank you for taking your time to participate with us in this exciting meeting. We're living a very tough time, I believe, due to this COVID-19 pandemic. And despite the tough times and the uncertainty that the world is passing through, there are some people who are tough and resilient and continue to pursue with their dreams. A few days back, we saw how Elon Musk was able to launch his first spacecraft, private spacecraft, into the International Space Station, and he had 2 NASA astronauts along. In the ophthalmology world, we believe that Dr. Muhammad Salah Zaatar is one of these people with great hope and vision, and very persistent in achieving his missions despite all the difficulties and uncertainties. Dr. Muhammad Salah was the Dean of the Memorial Institute of Ophthalmological Research, the Mayor, and he was the president of the General Organization of Teaching Hospitals and Institutes. He had a great vision for the institute as a whole. Let me first please tell you more about our institute. The Memorial Institute of Ophthalmological Research, Mayor, was first established in the early 1900s in the city of Asyut. It was then transferred to Al Mansoura city a year later, and then was relocated and established in Al Giza since 1918 till today. This is what the Memorial Institute used to look like, and this is how it looks like now. We have many historical impressions inside our institute. In the Memorial Lab, we see carved on the wall of honor that this lab was erected for the honor of the Egyptian labor and camel transports in the Great War. And we have a magnificent statue of Mr. McKellen, who is the famous ophthalmologist for the McKellen classification. And he is actually the person who established the Memorial Institute of Ophthalmological Research. And since then, a lot of developments have happened. Most recently, we have the Memorial Institute Research and Training Center that's under the supervision of Professor Dr. Hani Nasr. We also have the nursing school that was recently established inside Mayor, and we have rejuvenated all the ophthalmology eye clinics. Currently, Professor Dr. Layla Ishazli, she is the Dean of Mayor since 2018. As for strabismus, we had a strabismus unit established by Dr. Gamal Subhi. He was the head of the strabismus unit for about 20 years. Later on, Dr. Hiba Mitwalli joined the Mayor and established the pediatric ophthalmology and strabismus unit. A couple of years later, Dr. Ayman Al-Ghunaimi joined in, and they started expanding the practice of pediatric ophthalmology. Dr. Zainab Ahmed also joined the team. A lot of achievements have happened due to the collaboration and wonderful teamwork of our consultants, fellows, and residents. We have started from being only 3 doctors to more than 25 doctors, from 1 clinic to 4 pediatric ophthalmology clinics, from only serving 80 patients per day to serving more than 300 patients, pediatric patients every day, from performing 20 eye surgeries on children per month to more than 125 eye surgeries for children per month. This increase in the amount of patients and the number of surgeries has put a strong demand to have a dedicated pediatric ophthalmology center. And this dream was then transformed into a goal and a mission by Professor Dr. Muhammad Salah. A lot of hard work and teamwork and perseverance was put to achieve this goal. Dr. Hiba Mitwalli and Dr. Ayman Al-Ghunaimi took upon themselves the mission and the fulfillment of this goal. They literally started from scratch, and with the continuous work and follow-up from Dr. Muhammad Salah, the dream has become a reality. Welcome to the Memorial Institute Kids Eye Center. We have been honored to have visitors from all over the world and from Egypt. Our honored and well-known professors have visited us and gave a lot of support and encouragement for this wonderful center. I would like to take you into a virtual tour inside MIC, which is considered the first separate and specialized pediatric ophthalmology center in the region. We have 6 general eye clinics and specialized clinics. The clinics are well established and fully equipped with the highest and most advanced equipment available to serve best the children visiting Mayor and Mike. Let's take you to the first floor where the inpatient department is, where we have about 27 beds in the inpatient department between 2 sections, the free partition and the private and low-paid partition. As you can see, we have focused to make the decorations and the setup as friendly as possible to accommodate our children. Then we have the operation theater, where we have 3 operation rooms and 2 recovery rooms, all developed and with the highest standards of infection control and sterilization. The Memorial Institute Kids Eye Center also has the mission of giving more to the scientific field. We will start a series of grand rounds and webinars, and this is the first online grand round. I would like to please welcome and present Dr. Hiba Mitwalli. Dr. Hiba Mitwalli is a board member of the MIC. She is a consultant pediatric ophthalmology and strabismus in Mayor since 2014. She has had her fellowship in Maghrabi Eye Hospitals and is a consultant in Maghrabi till now. She established the pediatric ophthalmology unit in 2013. We would also like to welcome Dr. Ayman Al-Ghunaimi, who is also a board member of the MIC. He is a consultant pediatric ophthalmology and strabismus. He joined Mayor since 2015. He's a consultant ophthalmologist in Maghrabi hospitals since 2003. And he had his training as a fellow in the Bascom Palmer Eye Institute in the University of Miami in the USA. Please, Dr. Ayman.
Hi, Tariq.
Please, Dr. Hiba.
Hi, everybody who are watching us from all over the world, our friends, colleagues, and professors. I'd like to welcome you all to our first meeting. Thank you, Tariq, for this impressive and really touching presentation. You know, Mike is a word to me and means a lot to me. You actually remind me of all what had happened all over the last 2 years. Our meetings with Professor Dr. Muhammad Salah, our long nights planning, thinking, writing, designing, decorating, and teaching a young generation to be ready for this great and huge national project. Me and my colleague, Dr. Ayman Al-Ghunaimi, would like to thank Professor Dr. Muhammad Salah for all what he had done for our dream to come true, and actually for all he will as well for us in the MIC. You really teach us that our dreams can come true if we really had the courage to pursue them. We actually, me and my colleague, Dr. Ayman Ghanimi, would like to thank Professor Dr. Hani Salah Nasr, Professor Dr. Layla Shazli, Professor Dr. Hanan Ghanimi, Professor Dr. Nagla Hassan for their support to our project. We really want to thank the huge team of the MIC, not only the pediatric ophthalmology and strabismus and all, but also the pediatric cataract, the pediatric cornea, the pediatric retina, the pediatric ROP, the pediatric ocular plastic team, the pediatric investigations, and even the ophthalmic genetics team. We want to say today, hey, you can do this. You did it already. We have now the first pediatric ophthalmology exclusive hospital for pediatric eye problems and for kids in the region. Today, I want to give a special and many thanks to my dear colleague, Dr. Ayman Ghanimi. I actually enjoyed every moment to work with you all over the past 2 years on every detail. And also we'd like to welcome all the expertise from all over the world, inside and outside Egypt, to help us raise this. And for now, I think this day is a very special day, not only for me, but also for my colleague, Dr. Ayman Ghanimi, not just because this is the first scientific meeting of the MIC, but because today we're gonna present our super excited about this day, and I'd like to thank you all for your attendance and for being with us. And now, please, Dr. Ayman, give us a few words about how you feel and about the MIC.
Thank you, Dr. Heba. Thank you very much. Thank you, Dr. Tarek. Actually, this presentation is really very touching. It reminds us of the whole journey since we started DREAM from the beginning. Since that, for me, historic moment for me when Professor Dr. Muhammad Salah has assigned to Heba and myself for this huge project, a project of the first separate building, first separate center for pediatric ophthalmology, dedicated only for pediatric ophthalmology, including its own OR, its own investigative units. And so it was really amazing. It was a moment that it's a dream. It's we know that it needs really hard work for this, and we tried with everyone. Of course, starting with the dream of Dr. Muhammad Salah, till he's following with us every single detail in the center, to all the support from all the administration of the Memorial Institute. So I will not repeat again the name, but I'd like to thank everyone: Muhammad Salah, Dr. Hani, Dr. Layla, Dr. Hanan, Dr. Nagla, everyone. And of course, my consultants in pediatric ophthalmology, Dr. Heba, of course, and Dr. Zainab, Dr. Salwa, and all the pediatric ophthalmology team. And again, I would like to highlight again my appreciation to the engine of this, the fellows and the residents, the fellows of the pediatric ophthalmology who gave us actually the fuel. When we get tired, when we get feeling any frustration for any difficulties we face, we remember that we have a generation that's really eager to learn, and they deserve the best environment for them to grow. So it's very touching. It's an exciting moment. We were planning actually to start working inside the center like a month ago, but more than a month ago, but because of the COVID-19, we actually postponed the opening. But still, we decided to start the scientific activities, to start working actually in the MIC by the scientific activities. And this is not the first one. This is not the only first one. It's not the end. We will start by groups actually of scientific events. We'll include as much fellows as we have, as much residents as we have, because we won't talk about every subspecialty in pediatric ophthalmology. So the first step is the grand round. It will be on regular basis, to be repeated regularly. And plus, I'm happy to announce that we'll have international webinars with eminent names from Egypt, from region and international figures. And please follow our page and to be announced by every detail of the coming events. So I will leave the talk to Dr. Tariq. I'm glad that Dr. Tariq is taking over this moderation. Dr. Tariq is one of the fellows of the pediatric ophthalmology unit with us. Dr. Tariq has joined Mayor a long time ago in 2007 and got his FRCS in 2014. He was one of the most eminent fellows in pediatric ophthalmology, and I'm really proud of having him with us. And he will be the one moderating this session, and will be introducing the 4 fellows that are very dear to my heart, all of them. Dr. Tariq will start introducing them. Dr. Tariq, you have the microphone.
Thank you very much, Dr. Ayman. Thank you very much, sir. For tonight, we have 4 interesting strabismus cases by fellows of pediatric ophthalmology in Mike. By the order of their presentations, we have Dr. Bara Hilal. He is the most recent fellow to join our team in 2020, and he's well known for his eagerness for scientific references and articles. Dr. Sahar Al-Aigini is also one of the most eminent members of the fellows of the pediatric ophthalmology team. She joined since 2019, and she's well known for her kindness to her patients and her enthusiasm for teamwork. Dr. Isra Ramadan is one of the, I believe she's the oldest or eldest fellow in the pediatric ophthalmology unit, and she's a very hard worker with great dedication and great help to her colleagues. Last but not least, Dr. Mustafa Azab. He joined our team in 2018, and he's a very scientific person with a great helping hand in the teaching of the junior residents. Welcome, everybody, and I would like to thank especially Novartis for helping us launch this online scientific event and for their sponsoring of our scientific meetings. Thank you, everybody, and without further ado, I think I'll hand over the presentation to Dr. Bara Hilal. You're having the first case to present.
Thank you, Dr. Tariq, for the nice presentation and nice introduction. At first, I would like to thank Dr. Hiba and Dr. Ayman for giving me that great chance to participate in this special event. Today, I will be presenting a case under the title of Wait Before You Operate. Our patient is 32 years old female, presented by left ptosis and diplopia when the lid is elevated manually. This is followed a blunt trauma 10 months ago. She was referred to our unit as an old third nerve palsy with neurogenic ptosis seeking surgical correction. The condition started 10 months ago after blunt trauma by her husband, and she insisted that she was totally okay before that. The condition increased gradually with no pain or no diminution of vision. She had no history of systemic nor ocular diseases. She was given Mestinon at that time, 30 milligrams per day for myasthenia gravis, but she didn't improve. So upon that history, she was referred as a neurogenic ptosis for surgical correction. Upon examination, her vision was 6/6 bilaterally. Her pupils were regular, rounded, and reactive with no anisocoria bilaterally. Her anterior segment and posterior segment were also normal. Regarding the ptosis, it was complete and fixed for 10 months with no variability and no liver function. Also, the eye spec test was negative without any improvement of the ptosis after the test. And here is the video of Cook and Twitch sign, which was also negative with no upshooting when the patient moved from down gaze to primary gaze. And we also will notice when the patient looks at the left gaze, there is ataxic nystagmus in the left eye. Regarding ocular motility examination, the patient had right limited adduction. The patient had right limited adduction of -4. Also, she had left limited adduction -1. She had also limited left elevation of -2 and left limited depression of -2. This vertical limitation increased in the left gaze, as we see here and here, but improved in the right gaze, as we see here and here. So we have a bilateral asymmetrical bizarre ocular motility defect. Ductions, convergence, and vestibular ocular reflex were also affected. Her saccades were too slow. So this made us examine other cranial nerves, but they were totally normal. The patient came to us with an MRI brain and CT chest, but they were totally free. So upon the given information, what do you think is the next step? We will launch the poll now, and you can vote for your next step.
I would like to remind our audience that you can post your questions in the Q&A section, not in the chat section, please. And if there is anything that's left unanswered, we will be more than happy to receive it on our page. This is a very interesting case, Dr. Bara. Dr. Hiba, what do you think is the problem with this case? Dr. Hiba?
Hi, Bara, how are you? It's a very
Fine, thank you, Dr. Hiba.
actually a very interesting case that carries many possibilities of differential diagnosis.
Yes.
Actually, for me, it's a bizarre shaped ocular motility that would be due to any cause of the causes of the bizarre shaped ocular motility. For me, I would re-evaluate the myasthenia gravis, this case to be myasthenia gravis again.
Could you please show us the pictures, please, Dr. Bara?
Yes.
Other causes like the MS, for example, the bilateral cerebral palsy asymmetrical. It's for me, it's possible for many reasons in the case, but I would prefer if you present your work for this case and how did you receive how did you reach your diagnosis. But for me, about the answer of the poll, I would choose to reorder single fiber EMG and to repeat the MRI and to re-evaluate the case as a whole.
Okay, now we have a very interesting result here. Nearly half of the audience believe that we should repeat the brain MRI. And only a few, like 5%, went to strabismus surgery. And 40% believe that we could have ordered a single EMG or have ordered an anti-acetylcholinesterase receptor antibody. Dr. Bara, let me ask you, have you ordered for this the anti-acetylcholinesterase antibody receptor antibody?
Actually, we didn't, and we will see why in the next slides.
Okay.
Okay, we faced a great.
May I have a comment?
Yes, yes, of course, Dr. Ayman.
Yeah, this was an really interesting case. We have this bizarre actually movement. If you can show us, please, the pictures.
Yes.
Yeah, this is very interesting. This goes with limitation in both eyes. That's really bizarre for me. And I won't exclude myasthenia by all means in such cases. In such a case like this, I know that you you have mentioned that this you show the eyes pack test, you show the going Twitch sign, all this can be excluded, but I won't exclude this. But I think you mentioned the MRI has been done already, right? And it was normal.
Yes.
It's not about the idea to double check the MRI and to repeat it. you can do this, but still, I usually in such cases I take my time to exclude myasthenia, because this bizarre shape could in many cases it happened and appeared to be a myasthenic case.
Yes.
Dr. Bara, was the patient diplopic when you raised the lid?
Yes, yes, she was.
So,
Dr. Tariq?
yes.
Actually, I do recommend for all of you, if you have a bizarre shaped ocular motility and you have previous investigations, you have to repeat all the investigations. Don't you ever depend on the previous evaluation of the case. You might find another clues, another new clue to solve the problem of the case. And so I do recommend to repeat all the investigations, starting with the MRI and the myasthenia gravis.
Yes.
I mean, not only for myasthenia gravis, to re-evaluate all the case.
Yeah, I agree. I do agree.
Okay. Yes, Dr. Bara, please.
So we were facing too much pressure from the patient and from the oculoplastic surgeon. The patient was insisting to have her problem corrected surgically, and the oculoplastic surgeon also was pushing to align the eye surgically to allow him to correct the ptosis. But we resisted the idea of getting into surgery without having a definite diagnosis. So we decided to re-evaluate the case. We are facing a case of bizarre ocular motility defect for differential diagnosis. So let's think where could be the pathology and what it could be. It could be supranuclear, example as bilateral INO, nuclear third nerve palsy, or it could be paralytic, as in multiple cranial nerve pulses, as we see in cavernous sinus syndrome, or it could be myogenic in the neuromuscular junction transmission, or it could be in the muscles itself, as in restrictive disease. Regarding supranuclear and nuclear disease, it can be caused by multiple sclerosis, strokes, tumors, or inflammatory conditions. In paralytic condition or multiple cranial nerve affection, it can be caused also by trauma, tumors, vascular, or inflammatory diseases. Regarding myogenic or neuromuscular junction, it can be caused by myasthenia gravis, myotonic dystrophy, or other dystrophies. Regarding the restrictive lesions, it can be caused by thyroid eye disease or congenital fibrosis of extraocular muscle. Back to our patient, we can exclude restrictive causes as congenital fibrosis of extraocular muscle is presented since birth, and we have an acquired ocular motility defect. Also, the thyroid eye disease will present with different symptoms and signs, not that complete ptosis, not that pattern of ocular motility defect, as the most common muscles to be affected are the inferior rectus and the medial rectus. So, our main differential diagnosis is multiple sclerosis, myasthenia gravis, bilateral internuclear ophthalmoplegia, small vascular brain strokes, brain tumors, or both third nerve palsy. So, what it could be? We have the fixed ptosis, no response to mestinone, negative eye spec test, no levator function, which made myasthenia gravis unlikely. Also, we had the normal MRI, which made multiple sclerosis also unlikely. And we have the bizarre ocular motility defect that made third nerve palsy also unlikely. So it was a difficult puzzle to solve, but we decided to dig deeper and search for atypical presentations. We have ordered to repeat the MRI brain, searching for multiple sclerosis again, excluding brain tumors or vascular lesions, but it was also normal again. Then we ordered single fiber EMG for the epicularis oris muscle and the frontalis muscle. And this was abnormal, which gave us a clue towards myasthenia gravis. So we went to the mestinone test, which is the most reliable for myasthenia gravis. And after collaboration with the neurology consultant, we increased the dose of mestinone to 180 milligrams per day, which led to improvement of the ptosis. Here are the pictures before the mestinone, and here are the pictures after, with great improvement of the ptosis. As we all know, the response of the levator muscle is much better for mestinone than the extraocular muscles. And upon reviewing the literature, we found similar cases, One of them was published in 2060 by Pradyut Tiwari and co-authors. They published that the patient is presented with acute onset bilateral ophthalmoplegia without any prior history of suggestive of myasthenia gravis, also without any evidence of fatigability in clinical testing. Also, she has negative eye spec test, hydrophonium test, and repetitive nerve stimulation test. Another case, which was a 92 years old woman, was published in 2002 in the eye. She was presented also with bilateral total external ophthalmoplegia associated with bilateral asymmetrical ptosis. Also, there was no fatigability nor variability of the muscle weakness, which was elicited on clinical testing. So our message to our audience is to wait before you operate. Please don't rush for surgery in any bizarre ocular motility defect, and also don't consider double pathology that easily. Regarding myasthenia gravis, it has many atypical clinical forms and presentations. Its laboratory diagnosis is difficult, but single fiber EMG and mestinone tests are the most sensitive. Also, cases of myasthenia gravis respond to cumulative effect of treatment. Thank you very much for your time.
Thank you, Dr. Bara. So you saved her husband, I believe.
Yes, yes.
Okay.
It wasn't his fault.
Show us the pictures again, please. Why? That's interesting. Yeah, that's an interesting point. Of course, the history was for trauma in the beginning, and we have to consider trauma. But again, this bizarre shape can still help us not to exclude the myasthenia in such case. Yeah, please show us the picture.
Let me ask you, sir, how would you approach this case?
Well, as I was saying, okay, we have a history of trauma, and we have to respect this, and we have to put this in mind. But I mean, it's very hard to say that trauma can cause this. It has to be multiple cranial nerves in the trauma. This could be, again. That's why, okay, I agree definitely with repeating even the MRI brain for this. And of course, repeating the MRI can help us if we have a multiple sclerosis, can cause multiple affection. But the point is that the history was really misleading.
Yes.
Yeah, so it's the MRI can altering imaging to the orbit is not a bad idea, by the way. And as you can see, we have this limited adduction, the right limited adduction, the left limited adduction. Still, I know should be one of the cases, but of course it will not explain why you have ptosis. So we have like third nerve plus I know it's very complicated. Sometimes we have double pathologies, triple pathologies, but it's not that common. So for such case, really, I would go to the end with myasthenia. For myself, I would order not only single fiber EMG, but I can order also the supramaximum stimulation EMG, and I may request actually a styrene receptor antibody. I know that we are comfortable that we have the medical treatment, the mestinone, when the dose has been adjusted by the neurologist, she got improved. But we have to put in mind that sometimes mestinone can improve cases other than myasthenia. I mean, it's not just pathognomonic. Since she was improved on mestinone, so that's myasthenia. No, we cannot say this. Mestinone can improve some cases other than myasthenia. So we still put in mind, and I think we have to put things with the neurologist. Definitely, the opinion of the neurologist is very important in such case. What do you think, Dr. Heba?
Dr. Heba, can I ask you about the anti-cholinesterase antibodies? Would you order them?
Actually, I do not. And before I answer your question, Tariq, but just let me comment. I have one comment on the case. For all of the young generation, don't you ever be convinced with double pathology in the same case that easily. I like this stay home message that Dr. Bara just told us about. Because, for example, trauma cannot explain this motility defect in both eyes, and the motility defect in both eyes that does not follow actually a specific pattern of any of the known motility defects. It does not follow even the third nerve in one eye, sixth nerve in the one eye, even the multiple cranial nerve affection. It does not happen in both eyes with this pattern. And so try to re-evaluate very thoroughly all the cases with this type of bizarre ocular motility. I do best emphasize. As regard the anti-acetylcholinesterase antibodies, I actually do not depend on the anti-acetylcholinesterase antibodies for establishing the diagnosis, but I usually get curious in some cases, especially the atypical cases, and almost to be frank, in almost all the cases, I usually order just the single fiber EMG, and I depend on the Mestinone therapeutic test, which is the only sure test in a teamwork with a neurologist, of course. But in some cases, I get curious to know what about the anti-acetylcholinesterase antibodies, because I had a case that showed at the beginning of the treatment initial improvement on Mestinone, and then showed a severe deterioration. And when I consulted the neurologist, we found that it is a late congenital myasthenia gravis, and not a late presentation of the congenital myasthenia gravis, and not just the adult onset acquired myasthenia gravis. And it is very serious for those cases to give the Mestinone, and they need a different management, as was said by the neurologist at the time. And in all the cases, and I got curious, as I said, about the result, because in negative cases, in zero negative cases, I close the cases very closely, because I'm afraid in every case to be not just a seronegative myasthenia gravis, but of the congenital myasthenia gravis, which is a different disease with a genetical background and not an autoimmune background, and needs different treatment. It's all my experience and concern about the anti-acetylcholinesterase antibodies.
So it's not conclusive. The antibodies are not conclusive, because we can still have seronegative cases of myasthenia gravis.
Yes, it's not conclusive, but as I told you, my only concern upon my experience with my very rare case, I reviewed the literature at that time, and I find it's a very, very rare presentation, but it could happen in few cases.
Dr. Ayman, do you agree it's a very rare presentation?
Well, myasthenia can present with any plate, and actually I've seen a lot of atypical myasthenia cases, and so I always, very cautious to exclude myasthenia in most of the cases, especially if I decide to operate upon them. So yeah, yes, the same presentation is not common, but I mean the atypical presentation of myasthenia is quite common without any systemic manifestations.
Are they also quite common in the pediatric age group?
It can happen, of course, in the pediatric age group. I've seen a lot of kids having some manifestations, then they turn to be myasthenia.
Oh, that's wonderful.
Tariq, if we compare the incidence of myasthenia gravis in pediatric age group and in adult group, we would find that it is this common in pediatric age group in the adult group, but it present. You're gonna find myasthenia gravis in the pediatric age group if you search for them, if you put them into your differential diagnosis in the clinic. But actually, it's actually less common than the adult onset myasthenia gravis.
Mm-hmm. Okay, and well, what about when to intervene surgically in such cases?
The question for me, Tariq?
Yes, please. Yes, Dr. Hiba. When would you interfere surgically in such cases?
Actually, in this decision, I depend on the neurologist opinion. I just wait for the neurologist to just reach his maximum results with maximum regimen and a period of mestinon intake in the patient, and I just depend on his decision. When he asked me to go for surgical correction, I just do that. Actually, the cases that needs strabismus, surgical correction for strabismus due to myasthenia gravis is not very common. In my practice, I just saw 4 or 5 cases, as I remember, and I just did four cases only. I did for them surgical correction of this strabismus.
Dr. Ayman, let me ask you if there was persistent diplopia even after the surgery. How can we correct that?
Well, first the surgery first. I mean, usually I take time before taking decision for surgery. As Dr. Heba mentioned, that definitely the decision should be from the neurologist first, that the patient is stable and is free. And even if this many times the neurologist tell me, okay, you can operate, and then I wait. I take the measurements every time, and I follow the patients. And even when the neurologist say that the patient is stable, I have to make sure that the measurements are stable not before 3 months. Most of the time, I wait up to 6 months. During this period, okay, we can have prism. A lot of patients may need frontal prism. For this patient, of course, during the ptosis, she'll not complain of diplopia. But I mean, when the ptosis improves, definitely she will complain of a horrible diplopia. So we should, yes, like such case, frontal prism can do the job. Can do the job for her.
Okay, Dr. Ayman, do you believe that the myasthenia gravis explains the adduction defect that was present in this patient?
It could be. It could be.
Okay. And
I'm interested in that we, if you have questions from the audience.
Yes, I'm actually answering.
I'm checking that we have a lot of questions, and I'll be happy to know the experience of the audience in this. Let's have a look on the questions there. We have a question from Dr. Stephen Glazer, so I think that's an interesting question. Dr. Stephen have been asking about the adduction defect.
Yes, and was it improved with the mestinon?
Yeah, Dr. Bara, this question is for you. Dr.
Yes.
Stephen had asked for the adduction in the right eye, and did the mestinon improve the adduction defect in the right eye?
Yes, it actually improved, but not totally resolved. We refer the patient for the care of the neurologist, and she came for us just for follow-ups. And in these follow-ups, we noticed that the ptosis improved very early than the extraocular muscles, and also the movement, the extraocular motility improved, but it took a lot of time.
Oh, excuse me, Dr. Ayman, I have a question. This photo after how many days?
It was one week after starting the 180 milligrams per day mestinon.
Yeah, but I think that Dr. Stephen, if he's interested to introduce you, we can let him ask a question by audio. I don't think if it is possible, technically or not. But let's have a look on other questions. We have a lot of questions of many people. I have a question from Dr. Dina about the measurements in the primary position. Dr. Dina Hussain, welcome. About the measurements of the measurements in the primary position. Dr. Bara, can you remind us of the measurements in the primary position and with no hypo prime in the primary?
No, there was left hypertropia of 10 prism diopters. And there was exotropia of about 65 prism diopters. So here in our orthotic sheets, I know that the font is very small.
The writing is not very. Show us the picture and tell us. Yeah, I can show us the picture. Yeah. It's not very obvious in the primary position yet.
Yes, but during measurements, there was about 10 degrees of left hypertropia, 10 prism diopters hypertropia, and there were about 65 prism diopters exotropia.
Okay, تمام. Okay. And Dr. Dina still asked about the motility now. How is the motility now? This picture of after means after how long of adjusting?
1
the
week.
dose
This was after only 1 week.
Do you have any follow-up pictures for her?
Unfortunately, I don't have any further more pictures, but we saw her in further follow-ups, but we didn't have the chance to have photos.
Okay. Okay, that's the very different case.
We are actually running out of time.
A little bit tight in time, so Bara, I think your case is going to have a lot of discussions, and maybe we
Yes.
can refer our audience to the Facebook page
Okay.
because we're having more diplopias to come.
Okay.
Dr. Nice presentation, very nice presentation.
Thank you. Thank you very much, Dr. Ayman. Thank you.
I would like to introduce Dr. Sahar Al-Agimi with a surprise diplopia after cataract extraction. Please, Dr. Sahar.
Thank you so much, Dr. Tariq, for the nice introduction. Thank you so much, my dear professors, Dr. Ayman Al-Ghunaimi and Dr. Hiba Mitwalli, for giving me this opportunity to share my case with you today in the First Memorial Institute Kids Center Grand Round. Today, I'll present a case of post-cataract surgery diplopia. My case is 56-year-old female patient complaining from vertical diplopia, 3 months duration, with no history of any systemic illness, history of left phaco plus IOL implantation 3 months ago. By inspection, there is left hypotropia in primary position and mild aparentosis. This was the general examination sheet with the refraction of -1/4 in the right eye and -0.75 cylinder in the left eye, with uncorrected visual acuity 0.8, 0.2 in the right eye and 0.8 in the left eye, and best corrected visual acuity 0.7 in the right eye and 0.8 in the left eye. Anterior examination was normal in the right eye, and the left eye was pseudophakic. Posterior examination was normal in both eyes with no torsion. And this was the orthopic examination sheet. Ocular motility examination revealed left limited elevation on abduction, left inferior rectus overaction +2, and right superior oblique underaction. Orthoptic examination revealed left hypotropia in primary position, which increases in left gaze, up gaze, and left head tilt. On reviewing of the literature for common causes of binocular diplopia post-cataract surgery, anatomy-related was myotoxicity and direct muscle injury was the common cause. Pre-existing thyroidism disorder, most often heterophoria and decompensated fourth nerve palsy with large vertical fusion amplitude was the second most common cause. Optical and refractive complications like anisotropia due to the left eye is high myope or aphakic. Sensory deprivation by dense cataract, as in cases of long-standing cataract. After removal of this cataract, the patient may suffer from difficulty of fusion and diplopia. On reviewing of literature, this article discussed diplopia as the complication of cataract surgery and was published in the Journal of Ophthalmology in the year 2016. NIAC reported 150 cases presented with diplopia after cataract surgery. All of the patients had a form of regional anesthesia, peribulbar or retrobulbar. Some had also superior rectus stay suture applied during the surgery. And these cases constituted 30% of all diplopia patients treated in the clinic during this period. Also, Karagiannis reviewed 571 patients treated for diplopia over the period of 8 years. 6.8% had diplopia related to cataract surgery performed in peribulbar anesthesia without the use of hyaluronidase. The nature of anesthesia-related diplopia is predominantly vertical strabismus. Presentation is hypertropia or hypertropia, depending also on the time of examination. So the patient, as a result of inferior rectus paresis and myotoxicity of anesthesia effect, may present with hypertropia. And then after fibrosis, may present with hypertropia. The inferior rectus reported, however, these cases are much less frequent. Another article published in the Clinical and Experimental Optometry in the year 2014, which discussed etiology, management, and prevention of post-cataract surgery diplopia. The article discussed surgical or anesthesia trauma effect, which causes vertical diplopia, and strabismus of this type contributed to brittle suture trauma or superior and inferior rectus muscle, direct needle trauma to muscles or related nerves from retrobulbar needle, ischemic injury of the muscle from swelling and hematoma formation, and inflammatory reaction to subconjunctival gentamicin. It also described that the most common causes of binocular vision disorders after cataract surgery occurred in the left eye, especially if the anesthesiologist is right-handed. Another article published in JPUS in the year 2005 by Jamal Blake and other co-authors, which discussed inferior oblique muscle injury after peribulbar anesthesia presenting as ipsilateral superior oblique palsy. So back to our case, we are having left limited elevation on AB duction and left inferior rectus over action and right superior oblique under action. We are having left hypotropia, 30 prism diopter in primary position, which increases in left gaze, up gaze, and left head tilt. So it's time to launch our poll. And what's your diagnosis?
Can we pull up the poll, please? A very interesting case. Can it be a superior rectus paralysis, a left inferior rectus restriction, or a right superior oblique paralysis, or others? I encourage our audience to please participate in the poll. Meanwhile, I would like to ask Dr. Ayman, what does he think?
Well, that's an interesting case. It's always a challenge when we have a patient with diplopia after cataract surgery. Although we have some causes for this, like we commonly see decompensated strabismus before, that's quite common, but in this case, we have a true limitation. So that's very interesting. So although they have a three-step test, but I mean, by having this limited elevation, we think they have a pathology in the inferior rectus. And I would say, check the history of this patient about the local anesthesia has been used. What kind of local anesthesia are they using? Bupivacaine, like Marcaine, which is Marcaine or not? Because it has been reported that injury to the muscle, it can be a myotoxicity, but the myotoxicity could be direct to the superior rectus, or it's a direct injury to the inferior rectus. When we have a direct injury of the inferior rectus, although in the beginning we have weakness in the inferior rectus, but yet with time, usually the muscle that receives this bupivacaine start to have a kind of fibrosis, a kind of restriction, and the muscle start to enlarge, and we have this limited elevation. And it's about the time. So tell me, Dr. Saha, this picture is how long after the surgery?
This picture was 3 months after the cataract surgery.
You have any pictures for her immediately after the surgery? But have any idea what happened after the surgery?
Unfortunately not. We don't have any pictures for her. She presented 3 months to our department after cataract surgery.
Because we have studied the procedure in our institute by injecting bupivacaine, which is Marcaine, and it causes long-term strengthening of the muscle, initial weakening, and then long-term strengthening of the muscle. And we use it even in some cases of regular strabismus, exotropia. We inject Botox in the lateral rectus, and we inject bupivacaine in the medial rectus, and it really worked. So, but it has initial weakness. So, if we have a way to see the pictures after the surgery, and we have found that she has left hypertropia after the surgery, limited depression, and now after many months we have this picture, I would think that this was an injury to the inferior rectus. However, we cannot exclude other causes like any kind of cause, superior rectus, paresis, any association with nerve pulses associated. But I mean, I go most probably with this.
I believe the majority of the audience do say it is a restriction, Dr. Ayman. Dr. Hiba, let me ask you about your opinion. What do you think? Dr. Hiba?
Unmute yourself, yes, please.
Okay. For myself, with this result of the 3-step test, superior rectus palsy also cannot be excluded. The two possibilities, inferior rectus restriction and superior rectus palsy, both are possible, and I can never tell which is the correct pathology, except if I check the patient immediately post-operative to see the primary ocular motility defect pattern at the immediately post-operative, and after checking for a force induction test. If the force reduction test even was moderately positive, not very positive, you cannot exclude both scenarios, because you might have a secondary contracture of the inferior rectus or a primary inferior rectus pares restriction due to the injury during with the syringe during the local anesthesia. And so the late presentation of the patient to the clinic 3 months post-operative is really made this case really very interesting, and the diagnosis is not sure unless we see what is the results of the force reduction test of the inferior rectus.
Did you perform the force reduction test, Dr. Sahar?
Yes, we performed it in the day of the OR. And we'll see in the upcoming slides.
Okay, please.
Okay. So we have left limited elevation in AB adduction, -3, with left inferior rectus over action and right superior oblique under action. We are having left hypertropia in primary position, which increases in left gaze and in left head tilt. So even if the patient presented 3 months after left cataract surgery and it was difficult to determine the primary muscle affected, the patient is presented with hypertropia 30 prism diopters that increases on left gaze and left head tilt. So I decided that my provisional diagnosis was left superior rectus paralysis. I analyzed the case by correction of refractive error, patient counseling, and I offered temporary measures like Fresnel prism, inferior rectus Botox injection, or alternative. The patient refused to have or inferior injection, and after 3 months, so I decided to have surgery for this case. I found surprising inferior rectus with bulky. So for left hypertropia, I decided to do left maximum section 6 millimeters and starting centimeters. So in primary position with marked improvement of left elevation in abduction and no post-operative diplopia. Unfortunately, we entered the era of the COVID-19. She has done this surgery in the 1st of March, shows the patient skipped follow-up visits and didn't show up since then. Stay home message. Persistent binocular diplopia following cataract surgery is uncommon but extremely frustrating complication. To all cataract surgeons, you have to do complete pre-operative ocular examination and ask for old photographs for detection of long-standing or old superior oblique palsy with large vertical fusion amplitude, which can be masked and appears after the surgery. Calculation of the refractive power of the other eye to avoid anisometropia or anisoeconia after the surgery, and avoid peribulbar or retrobulbar injection, especially without the use of hyaluronidase to decrease the incidence of post-cataract diplopia. Immediate examination of the case after cataract surgery may resolve the diagnosis. When constant diplopia is achieved, post-cataract surgery treatment with prisms or surgery for strabismus can eliminate the problem in the majority of cases. Thank you.
Thank you, Dr. Sahar, for this wonderful case. Let me ask you, Dr. Dina was asking if you were able to see any fundus torsions.
Yes, there was no torsion.
There is no torsion. That's good. Okay. Dr. Ayman, I would like to ask you about the inferior rectus recession. If this is the case, we're dealing with a tight inferior rectus. Dr. Sahar, that's your final conclusion, that it's a tight inferior rectus, right?
Yes.
Okay.
How
Do you
tight?
think,
How tight, Sahar?
Excuse me, can you repeat the question?
How tight?
How
Severely
tight was so tight?
Too
And
tight
it was bulky.
or just
It was bulky.
severely tight?
okay. Dr. Sahar, do you believe?
A picture, please, of
Okay.
the patient. So, but the first reduction test is important. But I mean, I can understand you did it on the day of surgery. We can do it in the clinic after before the surgery and help us in the diagnosis. And one thing also can help us, because we had in the differential diagnosis that's something that can weaken the superior rectus. So it's good to have an active fourth generation test too. I mean, you do it with the first reduction. If it's positive, we can do active fourth generation test and make sure that the superior rectus is fine. And please would show me again the decision. So you did force reduction test and you found the inferior rectus tight. Am I right?
Yes.
Okay. But I mean, the superior rectus incision 6 millimeters, so that's quite interesting. And I think that this amount is quite big. Unilateral inferior rectus incision can really cause with time overaction with time, and I doubt it may cause even low lid retraction. And it's not present in the photo, but it can cause this. So I'm not sure how, for the surgery in such cases. If I decide to do a single lateral rectus recession, I have to thoroughly dissect it from the low lid retractors. Try to avoid the postoperative low lid retraction, and also for myself, I want to go for 6 for a single inferior rectus. I would think in less amount. But I mean, the results was fine for you.
Dr. Sahar, do you know the type of anesthesia that was used for this patient?
Actually, we don't have any information about the previous surgery.
Okay, all right. And why do you think that the incidence would be higher if hyaluronidase was used?
On reviewing the literature, the incidence of post-operative cataract diplopia decreases by using hyaluronidase, as it decreases the effect of myotoxicity.
Okay, all right, okay. Dr. Heba, do you think this is a primary or a secondary inferior rectus restriction that we're facing here?
As long as she found a severely tight and bulky muscle, so the inferior rectus restriction diagnosis would be more more possible, of course. I just want to ask you about the type of sutures you used in this case.
Actually, we used absorbable suture, but it's better to use non-absorbable in this case to avoid slippage of the muscle.
So, so the photo you showed, you just showed post-operative is just 1 week after surgery or 1 month?
Yes, it was 1 week after surgery.
Just 1 week after surgery?
Yes.
You might find surprises in this case.
Yeah, the depression the depression is not bad, but I mean, we know that it's quite common to have a late slippage of the inferior rectus when you have like 6 millimeters. I don't prefer doing 6 millimeters. And also, and of course, if I do it, I don't do it hang back, because routinely I do hang back in recession, but I never do hang back recession for such.
I did it scleral tunnel.
Okay. Actually, many times when I use when I need it as big amounts, I use even non-absorbable sutures.
This is actually a question from Dr. Wael Hamouda asking, can we do an inferior rectus recession more than 5 millimeters? Dr. Ayman, what do you think?
I agree with this question. I'll be conservative in do 6 millimeters, especially in one inferior rectus.
Okay.
I'm talking about such case, but sometimes when you have a significant restriction, but not in such case, like case of congenital fibrosis, for example. Yes, sometimes I do liberal recession of the inferior rectus. Sometimes even we can insert it alone, but in the case of severe congenital fibrosis, especially type 1 congenital fibrosis. But in such case, I would recess less.
How long should a person, a strabismologist, wait for a post-cataract extraction diplopia? When should he decide to proceed with the surgery in such cases? How long should he wait?
Okay. Well, that's interesting. But according to the cause of this of the diplopia after the surgery, if I'm thinking hematotoxicity, definitely I have to wait, because I know it will be variable. So I have to wait. But the reassurance is extremely important. Those patients are usually really stressed after phaco surgery. They expect perfect vision, and then they develop this diplopia. They really need a lot of. The main effort actually is for reassurance of the patient. And I can help also. Prism can do a lot for this. So I usually start with the prisms. If it's a big amount like this, I can start with Fresnel prism, and I don't operate unless it's stable, unless the angle is really stable. I've seen Botox written somewhere in the slides with Dr. Sahar. So I won't consider Botox when I think it's restriction. I won't consider it an option.
Okay. Dr. Hiba, how long do you think, for how long stability of such case until you can take the decision for a surgery?
I actually do not never operate such cases before 3 months post cataract after the surgery. It's my experience, and I can offer Botox for those cases. I can offer Botox for those cases. I just want, as long as we have now today a ground round, I think we have a lot of young generations, and we need to give many messages from the cases. Not just you need to you present a different challenging cases. In those cases, I would recommend in recessing or resecting the vertical muscles to expect to make any shift of the muscle at nasal or temporal to avoid extorsion, torsional surprises post-operative. And I do recommend and advise all of you to counsel those patients quite well. Those patients are already very frustrated, as Dr. Ayman just mentioned, please counsel all patients about that they might need another surgery or a post-operative prism in the glasses. You need to talk with those patients for enough before you go and do such surgery for this case. And I think in this case, hopefully not, but I think you might find some surprises, Sahar, the next days.
Well, Dr. Sahar, I hope you have some good news in the follow-up of this case. And
I hope so.
okay, let us go forward now with Dr. Isra and more tricky restrictions. Dr. Isra, please.
Good evening, everyone. And the sound is clear now?
Yes, the sound is clear.
Okay. My presentation is clear.
Yes, please.
Good evening, everyone. I'm so glad to be here today to present my case in our first grand round in Memorial Institute Kids Eye Center, and it's my great chance to express my gratitude to my mentors, Dr. Ayman and Dr. Heba, for their continuous support. My case today is tricky hypertropia. Our case came to our department, is 36 years old male, came complaining of deviation of his left eye when he was young. There was no history of the previous operations, systematic disease, or any trauma. There was only a family history for a squint in his mother. By examination of this patient, the right eye unaided visual acuity was 6/12, the left eye was 3/60, the right eye corrected to 6/9, but the left eye is not corrected. By doing the autograph, there was an anisometropia -5 and -3 at 70 in the left eye, and this may explain the uncorrected visual acuity. Otherwise, the patient was totally free, the anterior segment was free, the posterior segment was free. And by examining the extraocular motility, we found that the left eye has a limitation in both abduction and abduction, but abduction more than abduction. There was an overshooting in the up and in position, and in the abduction also. There's a limitation in the down gaze, both in adduction and abduction. In the right eye, there was a limited abduction. Sorry, there was a limitation in the up gaze, both in the abduction and the adduction. The patient has an XT 25 present diopter in the primary gaze with left hypertropia 25. This XT increased to be 50 present diopter in the right gaze with left hypertropia 35, and it's reversed to be ET 18 present diopter and left hypertropia 30, up gaze and down gaze mostly look like to be like the primary gaze. And so this was a video of the patient. He has hypertropia, and there was a globe retraction of the intended adduction and lid retraction. There was a limitation in the left eye in both abduction and adduction. There was a limitation also in the right eye in superior gaze. In down gaze, there was a limitation in the inferior gaze in the left eye, both in adduction and abduction. So this was the orthoptic sheet of the patient. The patient has a XT and hypertropia in the primary position, and we are facing a case of Duane type 3 plus hypertropia, because we have limitation in both abduction and adduction, and we have also globe retraction and lid retraction on an attempted adduction. But we have also a hypertropia in this case. So what do you think is the cause of hypertropia in this case? It's a time to run the ball now. Do you think the cause is an overshoot in this case, or an inferior oblique overaction, superior rectus contracture, overshoot plus superior rectus contraction?
Okay, so what would the cause of this hypertropia be? An overshoot, an inferior oblique overaction, a superior rectus contracture, or an overshoot plus a superior rectus contracture? It's a very challenging case, I have to say, Dr. Isra.
Yes.
Dr. Hiba, what do you think?
Dr. Hiba, please unmute yourself.
Hi. A very nice case. Thank you.
Dr. Hiba.
As regard this case, I don't think this case is just an overshoot. It is a true hypertropia that could be due to overaction or superior rectus contracture or tightness. Actually, in this case, I need to check fundus extorsion. And if there is a fundus extortion, I would consider the cause is the inferior oblique overaction. And if there was no fundus extortion, I would consider it is a superior rectus contracture.
Okay. Dr. Isra, can you please pull up the picture of the photos of the patient again?
I just, it's interesting that this patient had a limited depression, as I remember from the photos.
Yes, he has a limited depression in the left eye, in both in adduction and abduction.
Okay.
Dr. Ayman, the audience, like 2/3 of the audience believe it's an overshoot and a superior rectus contracture. Do you agree with them?
Yeah, please keep the pictures, please. Let's discuss on the pictures. But yeah, the picture. Yeah, thank you very much. Well, of course, I think I agree that we have some sort of upshoot, but I mean, one of the main points here that we have a real hypertropia in the primary position. So this has to be considered, and plus that this kind of some limited depression goes with us that we have some sort of really restriction of the left superior rectus. Plus that the hyper, if you can see that hyper increased a little bit on the left gaze. So if it is only upshoot, I wouldn't expect to have a left hyper in the primary position and definitely not in the left gaze. So that's mainly definitely when you have a hyper, and especially in all three in the primary and right and left gazes. So this is for sure a kind of superior rectus contraction or a kind of overaction. Sometimes this could be innervational, like a kind of misdirection between the medial rectus and superior rectus. Sometimes it can happen, and it's very important in such cases to differentiate if it is just an upshoot or a true hyper. So the key here is with the alternate cover test is very important. If we do the alternate cover test, so it's hyper, it means it's the left comes from up and the right comes from down. I mean, we have left hyper and contralateral hypo. This means that we have a true hypertropia. It's not just shooting, because the shooting doesn't have hyper-hypo. The upshoot is a mechanical phenomenon, so it doesn't obey the Heron's law. So for having this significant hyper, and I assume this has been done by alternate cover test. Am I right, Dr. Isra?
Yes, yes,
Yeah.
it's a very key point here to be able to differentiate between true hypertropia and this. What I will tell you in the next slide.
And the prism was on the left eye, so it's about the primary angle. This is what I assume this happened.
Yes.
Am I right with it? Interesting. So I really go with the superior rectus contraction. We can have some superior rectus, some overshoot too.
So did you do the first adduction test intraoperatively, Dr. Isra?
Yes, and we will see in the upcoming slides.
Okay, please go ahead.
So when I did a review of literature about such cases of the Duane retraction syndrome, which is accompanied with a vertical deviation, I found one paper in 2012. It talked about 3 patients of a vertical deviation with type 3 Duane retraction syndrome. Another paper in 2014. It was an Indian one, and it was a brain contraction syndrome with a severe upshoot and ipsilateral severe rectus contraction. And by discussing with my dear professor, Dr. Ayman, he told me that he had a similar case back in 2007 that was presented as a poster European Strabismological Association meeting, Greece, 2007. And by searching more and more, I found that the theories in vertical muscle abnormalities in Graves syndrome, maybe it's due to an anomalous innervation of the vertical rectus muscles, which was postulated by Hooper back in 1974 and maybe earlier. And he postulated that this is a type of misinnervation, and he confirmed that with an EMG study. He found that severe rectus was firing at the same time of upshooting on attempted abduction. But Jampolsky thought that there was no anomalous innervation to the vertical muscle, and the EMG findings that was found by Hooper earlier before this were due to passive changes in the muscle, as the eye depress or elevate for the other reason. And he concluded that the EMG findings was due to that the superior rectus contracture due to repeated overshoot and repeated up and down elevation and depression due to the left lateral rectus bridal effect. So he didn't convince about the theory of misinnervation. So our possible causes of vertical deviations in Green syndrome, maybe it's an upshoot and downshoot due to the bridal effect of the lateral rectus, or maybe due to inferior oblique muscle overaction, or maybe due to secondary superior rectus contraction. How can we differentiate between these cases? If we found that the hypertropia only found if the eye is taken in and up position, the eye is taken above the middle line, this is mostly due to a bridal effect of the lateral rectus, especially if we find also that we have a downshoot. This may confirm the case. And if this was not the case, we have two possibilities: a superior rectus contraction or an inferior oblique overaction. How can we differentiate? We can differentiate, as Dr. Ayman and Dr. Hiba said, we can differentiate by doing both superior rectus force abduction test and also by fundus examination. If we found that the fundus force abduction test is positive, so it's mostly due to a superior rectus contraction. If it's negative and we found that the fundus has an extorsion, so it mostly due to an inferior oblique overaction. And also this is a flowchart to try to differentiate between the causes of hypertropia in a case of Duane in the primary position. If we find the hypertropia in the primary position, we must ask ourselves if there's a hypertropia or not. If not, it's okay. Maybe it's an overshoot, because overshoot sometimes causes hypertropia and sometimes does not cause any hypertropia. If yes, we have to ask ourselves if it's more than 15% diopter or if less than 15% diopter. If it's more than 15% diopter, we have to suspect that the superior rectus contraction, and they can confirm by positive force abduction test. And also a key point that was mentioned by Dr. Ayman, we have to do cover and cover test, because this is a true hypertropia. And if we found a hypertropia in this eye, we have to find that there is a hypotropia in the other eye. And if we find that the hypertropia is less than 15% diopter, we have to think in two possibilities: inferior oblique overaction or an overshoot. If inferior oblique overaction, we find a fundus extorsion, and also we find a hypotropia in the other eye, because this is a true hypertropia, which respects the laws of equal innervation between both eyes. And if it's less than 15% diopter and no hypotropia in the other eye and appears only in and up position or above the middle line, especially if it's accompanied with a downshoot, so it's mostly due to an overshoot. So back to our case, we have a case of Duane retraction syndrome type 3 with an XT 25% diopter in the primary position with left hypertropia 25% diopter. So we have a hypertropia more than 15% diopter, which raised our suspicion that this is not only due to an overshoot. So we did a force abduction test intraoperatively, and we find a positive force abduction test. So our decision for this case was a left lateral rectus recession 9 millimeters and superior rectus recession 6 millimeters. And this was the patient post-operative the patient is nearly also in the primary position. We still have limited abduction and adduction, but at least in the primary position, he is ortho. And post-operative, the patient is E-fleck in the primary position with left hypertropia fleck in the right gaze XT20 and left hypertropia 6, in the left gaze ET25 and left hypertropia 8. So my stay-home message from this case is that the Duane case is sometimes associated with vertical deviations, and alternate cover test is mandatory in these cases, and it's a key and can differentiate between true hypertropia and overshoot. Because in a true hypertropia, if we find a hypertropia in one eye, we have to find a hypertropia in the other eye. But it's something or some case that does not respect the laws of equal inhibition between both eyes, so it may be an overshoot. The amount of hypertropia also does matter in these cases. And thank you so much.
You're more than welcome. Thank you, Dr. Isra. This is a wonderful case. I would like to ask you about the history because Dr. Ahmed Samir was asking about the history and the onset of these limitations. So can you repeat them for us, please?
Yes, the limitation started since first. The deviation started since first. The patient came to us telling us that I have this deviation since first.
Okay. Dr. Heba, I would like to ask you, please, what would you do if you were in Isra's shoes?
Isra actually did a very good job and have a very nice results. But you know, strabismus is very interesting because we all might have different opinions. Actually, if I were in your shoes, I would do bilateral asymmetrical lateral rectus recession with the left lateral rectus with the smaller amount of recession, and also the superior rectus recession. And actually, in all cases that if I decided that this case is just a superior rectus contracture and not an upshoot, I just add a Y-split recession with the small recession. For example, I would do 4 millimeters or 3 millimeters recession with a Y-split, and the other eye I would do the larger recession with the superior rectus recession. Good job, very interesting case, and very nice flow chart. Very nice flow chart.
Yes, indeed, it's a very nice algorithm for us to settle where the cause can be. Dr. Ayman, can you tell us more about your paper with Dr. Salama?
Yeah, first of all, the very nice presentation, Dr. Isra. Thank you very much.
Thank you so much.
Well, and the interesting that I underwent the review of literature. So I remember that time when presented it as a poster in 2007, and we searched in the literature how many reported hypertropia in Duane. It's not too much, and I wonder if it's still now it's still not too many reports for this. The main point, and if you don't mind, Dr. Isra, show us the pictures again. Is that's the main point, is that it have hyper in the primary position and in the left gaze. This go and then we are dealing with superior rectus contraction, and we have to attack the superior rectus. I know that different opinions, as my colleague Dr. Heba just said, can have different opinions, and of course I agree with her about splitting the horizontal amount between both lateral recti. Definitely we can do so. But the point is that we have to do the superior rectus. We cannot rely on Y splitting only, because this they will not correct all this hyper. If we have a significant upshoot that we don't see the cornea while we are upshooting, and we don't have hypertrophy in the primary position, yes, we just do Y splitting of the lateral rectus and can be enough. But since we have a real hypertrophy in the prime and in this amount, we have to attack the superior rectus. And we mentioned the force reduction test. In this case, it was positive, right? Dr. Isra?
Yes, it was positive. We
Yeah.
did it intraoperatively, and it was positive.
Yes, and if I find negative, I should do exaggerated force reduction test to make sure, because the findings we'll go for this. So that's very interesting, and the result was fine.
Thanks God.
You have questions from audience?
Yes, Dr. Ahmed Awadin is asking, why would an overshoot show as a hypertropia in primary position if it's mechanical?
Yes, I agree with this question.
Would never show as a hypertrophy.
I agree with this question. If we don't see that, that's what I meant. If whatever the upshoot is huge, if you don't have hyper in the primary position, so this is not a point of superior rectus, then we have to, we don't operate on the superior rectus. We can do wide splitting of the lateral rectus, but we don't do this. But so if we have a significant hyper in primary, so we have a problem with the superior rectus. I agree with this opinion.
Yes, and
I think Dr. Ahmed means why I do about why we do why split recession. While I just meant that even if I'm not convinced that the patient has upshoot and I had a true hypertropia, I add the Y split recession to the small amount of the lateral rectus. When I have a true hypertropia, I add splitting of the lateral rectus with the superior rectus recession. To avoid any leash effects.
And the amount of hypertrophy doesn't matter, as I mentioned, because if it's not found, it does not mean that there is no overshoot. Maybe an overshoot and there is no hypertrophy, and it may be very slight hypertrophy. And the point is, if it's a significant hypertrophy, we must think about other cases of hypertrophy accompanied with an overshoot.
We have to, that's point we have to be careful for.
Yes.
If we have a hyper, I mean, when you do alternate cover test, we have left eye comes from up, right eye comes from down, so we have a true hyper.
Hyper, yes.
Get to tackle the superior rectus. But I mean, if we don't just have an upshoot, when you do alternate, if it's only upshoot, when you do alternate cover test, yeah, the upshoot eye comes from up, but the other eye doesn't come from down. Because it's not true hyper. Yes.
Dr. Dina Hussam likes to add a point to what Dr. Heba said. She's saying a very nice point, Dr. Heba. I would also consider adding a left lateral rectus Y splitting to relieve the significant leash. But still, the superior rectus is a must in this case due to the positive force reduction test. The left hypertrophy in the left gaze.
I mean, because you are friends, Dr. Heba and Dr. Dina, so she's supporting you for this.
Why did thanks.
This could be a point, yes. Yes, could be a point, yes. But I believe in such case, when you do a lateral rectus recession to the superior rectus, I can assume this could be fine with the upshoot. But if you have only upshoot, yes, the Y splitting is a must.
Okay, I believe we are only left with the final case, and Dr.
Thank you, Dr. Isra.
Thank you. Thank you.
Thank you very much, Dr. Isra. It's a wonderful, as usual. Okay, I would advise the audience to grab a cup of coffee in less than 30 seconds because the coming lecture with Dr. Azab is going to be something. Dr. Mustafa, we're all with you.
Dr. Tariq, thank you for your nice introduction. I'm very honored to present my case in the first grand round organized by our beloved Mike. Thank you so much. It's entitled Surprising Ptosis. A female patient, 17 years old, she's medically free, complaining of dropping of left eyelid. Started when she was 3 years old after severe head trauma. After the head trauma, she started to face ptosis and deviation. By history, she was diagnosed as a traumatic third nerve palsy. The plan was initial observation, then surgery if needed. After a few months, she had 2 successive surgeries to correct ptosis, unfortunately with no improvement. 1 year ago, she started again to seek medical advice, but she was told that nothing could be done. On examination, the left eye vision is counting finger 50 centimeters with no more correction. The right eye is 6'6". There is the pupils were rounded, regularly active with no wrap. Left upper lid ptosis with obvious scar. The upper lid is shortened with absent Bell's phenomenon. There were lower punctate erosions, and fundus showed no cyclotorsion. Motility examination, as we can see, she has lid elevation with adduction and abduction. As you can see, she also had limited elevation and depression in both adduction and abduction. What about the orthoptic evaluation? In primary position, she had left hypotropia 25 prism diopters and only exotropia 5 prism diopters. The hypotropia increased up to more than 50 prism diopters in the up gaze. That's due to the limited elevation, and turns into left hypertropia 15 prism diopters in down gaze, and this is due to the limited depression. As we can see from the photos, on the right gaze or on the left eye adduction, the lid is raised up, as we can see. And what is surprising here is lid elevation with abduction too. Also in down gaze, the lid is not going down, mostly due to the shortening of the previous ptosis surgeries. Now, what would you do in such case? If we can bring up the poll, please. Don't touch these patients. Would you do left inferior rectus recession and superior rectus tucking? Would you do right inferior rectus tucking or resection and superior rectus recession? Would you do left superior oblique transposition, or would you correct ptosis with a sling surgery or other lid surgery?
Once again, Dr. Mustafa, can you please bring the photos?
Okay.
Thank you. A very interesting case, Mustafa.
Yes, indeed, yes. It's very rare.
Yes.
To find lid elevation in a third nerve palsy with abduction.
Mm-hmm.
Oh, it's
Dr. Ayman, what's your opinion about this case?
That's quite interesting. We have trauma. We have a patient looks like a third nerve palsy. She underwent, but are you sure she underwent only lid surgeries, right? She didn't underwent any kind of strabismus surgery. Am I right?
Oh, no. She didn't do any kind of strabismus surgery.
What's interesting is the elevation of the lid in abduction, in abduction. That's quite interesting. It's very logical to have this elevation in adduction, but it's not expected to have its elevation in abduction. I think definitely we have some sort of a rare association for this. And of course, I have to check for old photos before the trauma, make sure that there was no any pre-existing pathology. And of course, I have to check for any for other cranial affection, like to check for the fourth nerve by checking the torsion by.
I have checked for the fourth nerve. She has no left intorsion in down and right gaze, and the fundus.
Yeah, that's extremely important. I agree with you. It's really extremely important. So when I ask her to go to down gaze, you look for any kind of intorsion. So she didn't have so. She didn't show any kind of intorsion in down gaze. Am I right?
No. There is no intorsion in down and right gaze.
So maybe you have an associated fourth nerve palsy also.
Yes, it's up till now it's a case of combined third and fourth nerve palsy.
And what about the corneal sensation?
The corneal sensation were intact. It was intact.
Yeah, we have to check if there is any associated also paralysis with fifth nerve pulse with fifth nerve.
I think the punctate epitheliopathy was due to the defective lid closure and the absent Bell's phenomenon.
But did you check for the corneal sensation, Dr.
Yes.
Mustafa?
Yes, it was intact.
Yes, that's extremely is one of very important, one of the most important points in this case.
Yeah.
Well, interestingly enough, 1/3 of the audience are telling you don't touch this patient, Mustafa. How do you feel about that? Okay, and a little bit more than 1/3 would proceed with the left inferior rectus recession and a right superior rectus tucking or resection. And 1/3 are divided between a right inferior rectus tucking resection and a right and superior rectus recession, a left superior oblique transposition, and 10% agree to just correct the ptosis and leave her alone. Dr. Heba, what do you think?
Actually, I was to ask Mustafa after he said that there is a superior oblique under action in the case, as long as it is a case of multiple cranial nerve affection, I would never touch it before making sure the corneal sensation is intact.
Yeah, agree.
First of all, this is obviously a case of apparent regeneration with abnormal apparent regeneration of the third nerve to the sixth nerve, and might be due to a multiple cranial nerve affection, and the sixth nerve was also affected at the first place post after the trauma. My management of this case, I don't want to say something you wanted to say, Mustafa, about the case, about your evaluation of the case, and I'd like to listen to your management to the end, and I will make my comment at the end of the case.
But Dr. Heba, is it common to have an aberrant regeneration between the third and the sixth nerve?
Rare. It is reported, but it's very rare.
Mm-hmm. Okay.
Yeah, your question to talk about the elevation in abduction, of course, in abduction.
Yes, yes.
Oh, yeah, that's extremely rare. Yeah.
In abduction, it's rare to find an apparent regeneration between the third nerve and sixth nerve while regeneration.
Yes, because usually the trauma is to the third nerve, so we have a misdirection. We have misdirection between branches of the third nerve. We don't expect to have regeneration with other nerves.
It's a big case. It's a big case. It's very interesting.
I think Dr. Ahmad Awadin is also agreeing because he's saying that why does the eyelid elevate in abduction? Would you consider combined third and sixth nerve palsy with synkinesis? This has been reported.
Yes, at the first place.
Yes. Okay, we're all eager to listen more. Dr. Mustafa, please proceed.
Actually, that's what what we are going to know through the next slides. Okay, can I continue?
Yes, please, Dr. Mustafa, we're all with you.
Okay, classically, we know that in some cases of third nerve palsy, aberrant regeneration takes place in the form of lead elevation in abduction. That's what's classically known. Other less common reported forms may happen. For example, pupillary constriction in abduction. Simply, these forms resemble abnormal acquired connection between the branches of the same nerve, the oculomotor. But apparent regeneration of the oculomotor in the form of lead elevation in abduction is extremely rare. And it means that there is acquired misconnection between different nerves, the oculomotor and the abducens. This was the first surprise. By literature review, as much as I could search, I didn't find similar cases except one case reported in JPOS in February 2005 by Buckley. In this paper, 3 cases were reported. 2 of them had lead elevation with abduction. One was bilateral, and the other case had surprising adduction on attempt abduction. There are other reported few cases of acquired misdirection between the oculomotor and the abducens. but due to different etiologies like brain tumors or cerebrovascular causes, and in different forms like pupillary constriction on abduction or adduction on attempt abduction. Now, how can I correct these ptosis and this deviation? I'm facing too many challenges. The patient had previous 2 failed ptosis surgery. She had scarred short lid. She has incomplete closure of the lid. There is no or there is absent Bell's phenomenon in the left eye. Patient is in chronic use of lubricants. She has some lower punctate epitheliopathy. We have underacting superior rectus, underacting inferior rectus, and also superior oblique muscles. And we have minimal horizontal deviation. And also 2 doctors before me advised her not to do any intervention. I started to think I can make use of the aberrant innervation if I can increase impulses to left medial rectus or lateral rectus, ptosis will be corrected. But how? As simulation of my idea, I used base in prisms and base out prisms in front of the right eye, the sound eye or the driving eye. And I found that more lid elevation with base in prisms than base out prisms. It is to say more lid elevation with stimulating the left medial rectus. With 50 prism diopters base in front of the right eye, I got almost total correction of ptosis, as you can see from the pictures. I got my answers. I put a plan. I counseled the patient and her mother. I told her we will need 2 to 3 surgeries, and they accepted. What was the decision of the first session? I did right lateral rectus recession, 9 millimeters, with medial rectus resection, 6.5 millimeters, and tendons shifting down. I also did left lateral rectus resection, 9 millimeters, and medial rectus recession, 5.5 millimeters, with shifting the tendons up. Okay, simply I weakened the right gaze by the lateral rectus recession and left medial rectus recession, and I strengthened the left gaze by right medial rectus resection and lateral rectus resection. By weakening the right gaze and strengthening the left gaze, now the brain will send more impulses to right gaze muscles, which are the right lateral rectus and left medial rectus, which will in turn correct the ptosis. Results after the first surgery, 6 months post-operative. Pre-operative, we had the palpebral fissure was 3.5 millimeter in primary position, and the lid was covering the pupil. Post-operative, after the first surgery, now it is 6 millimeters. The lid margin is now bisecting the pupil. The second surprise were intraoperative. I found an atrophic lateral rectus, which I didn't expect. I expected in a case of combined third and fourth nerve palsy, I will find an atrophic medial rectus and a normal or hypertrophic lateral rectus, but this was not the case. I found an atrophic lateral rectus and a normal medial rectus, and I started to think again. I have left lateral atrophic lateral rectus and normal medial rectus. I have minimal horizontal deviation. I have acquired misdirection between the oculomotor and the abducens. I started to guess, could it be a case of combined third and sixth nerve palsy? And if so, it explained the acquired misdirection between the 2 nerves. Now to the outcome. According to the lid position, we got about 2.5 millimeters from 3.5 to 6 millimeters improvement of the palpebral fissure in the primary position after the first session. According to the lid position, now I need only a base in prism with 20 prism diopters to correct the ptosis instead of 50 prism diopters pre-operatively. According to the deviation and the motility, preoperatively, I had left hypotropia, 25 prism diopters in the primary position, and 5 prism diopters exotropia with -1 limited adduction. Post-operatively, I have now 15 prism diopters hypotropia and exotropia 20 to 25 prism diopters with -4 limited adduction. And this is the third surprise. According to the patient, she is satisfied and actually she is excited to do the next step. What about the next step? If you were in my shoes, would you proceed for the next step? If yes, what would it be? Thank you so much.
Thank you very much, Dr. Mustafa. Really, this is, I would say, a super exciting way to finish this webinar or the grand rounds. Let me ask you, please, Dr. Mustafa, are you with me?
Yes, I'm with you, Dr. Tariq.
Yes, thank you. Dr. Amal Al-Hamadan is asking, can this be a post-traumatic Brown syndrome?
Post-traumatic Brown syndrome?
Yes.
No, I don't think so. Due to many causes. Obviously, we have limited abduction. We have limited elevation in both adduction and abduction. We also have limited depression in both adduction and abduction. This is not a typical picture of acquired Brown syndrome. And I have no positive force reduction test for resembling Brown syndrome.
Dr. Ayman, would you like to comment about this? Do you agree with Mustafa? It's not an acquired Brown syndrome?
Well, it's very courageous to operate in such patient. First, very nice, very interesting presentation. Thank you, Mustafa. Really, I'm proud of you. That's very interesting. But again, I think please keep the pictures, please, for us to comment about the pictures.
I didn't.
Yeah, the pre and post. This slide is nice. Well, I think the main concern for me is the cornea. Actually, I would really be afraid about anything that can alter the cornea. And again, you mentioned the cornea cessation in the midst. If I'm sure that the cornea cessation is good, and mentioned the Bell's phenomena also can be checked, I definitely have to consult a cornea consultant for about the health of the cornea. And for sure, I will not push for any lid surgery at least at the time being. So that's why it's very interesting, and it's amazing that you try to correct this lid position by moving the whole gaze of the patient. That's quite smart from you. But I have many questions here. One of the questions is, you have a significant hypo in the primary position, like 20 or 25, as much as I remember it.
Yes.
So, and you didn't operate in any vertical muscles.
Actually, I didn't operate any vertical muscles. I have severe limitation of elevation and depression in both adduction and abduction. I almost have no tone in these muscles. And the second cause, that if I operated the vertical muscles, I will lose the chance to use the aberrant innervation and work on the horizontal muscles. I can work on 4 muscles of the same eye due to the risk of anterior segment ischemia. So I choose to work on the horizontal muscles.
Yeah, I agree with you. If you decide to operate on a vertical muscle, you don't do it with the same, as you mentioned, 4 horizontal recti at the same time. However, of course, as you may know, we have other options to spare, like this is sparing technique described by Dr. McKeown, or you may think in anything else in the vertical. But I mean, the upshoot and downshoot, I don't expect that it will improve the hypo quite significant. I can understand that you are short of options in the left eye, but yes, you may think in the right eye, you may think so. But I mean, that's quite interesting, and I like the idea of having doing
the secondary angle was actually very large. I think I will not be able to correct the vertical deviation with working on the right eye.
What do you think, Dr. Hiba, about Dr. Mustapha's case?
Actually, I have many comments on the case. If I were in shoes يا مصطفى, يعني طبعا first of all, thanks for the case. يعني I think it was very interesting before the surgical intervention, Mustafa. And يعني it's very interesting case. And a very brilliant way of thinking. I agree with you. I like the strabismus surgeries with innervational background. I like it. But for me, it's very difficult to comment on ptosis while the eye is not in the primary position. I want to ask you, where is your measurement and evaluation of the ptosis in your preoperative evaluation? If I were in your shoes, I would neutralize the left hypertrophy even with prisms, and then comment on the ptosis and measure the MRD, comment on the levator function, because in those cases you might have a pseudo leading ptosis that the lead might follow the hypertropic eye. This is a preoperative. In my preoperative evaluation of the case. In the operation, in the surgical intervention, as long as you counsel the patient about the possibility of many surgical intervention, why, if I were in your shoes, I would never neglect the left hypotropia in my first intervention. I would try to correct this hypertropia, and I would examine the fundus for intorsion or extorsion, and I try to make my decision. And then I might try your half plan. I would be more conservative in approaching this case. Just for example, recessing the muscles to one gaze. For example, the lateral rectus, right lateral rectus, and left medial rectus recession. Another thing in the surgery, this outcome, this large XT exotropia is, for me, is non-satisfactory outcome.
Yes.
This adduction. This limited adduction, what do you think? I have comment on this limited adduction in the left medial rectus. It's not. Would you please tell me again those pictures after the surgery? How long after the surgery?
6 months after the surgery, but actually this was the same results 1 week post-operative too.
Show us the numbers post-operative.
What's it, Dr. Ayman?
The numbers, the measurements of the post-operative.
These are the numbers of the palpebral fissure.
No, the angle of deviation, I mean.
Angle of deviation.
The angle of deviation is now hypotropia 15 prism diopters in primary position, and exotropia 20 to 25 prism diopters. Yes, that's are the numbers.
Yeah.
Okay, go ahead. For me, it is either a slept muscle, or if I were in your shoes, I would change my plan if I explore and find a left lateral rectus atrophic. I would think that it's not a pretty normal medial rectus to recess it 5.5 or even 6 millimeters. I would think that this is a subnormal muscle, but it looks normal with only -1 adduction, because it's actually acting against a weak atrophic lateral rectus muscle, and I would decrease my amount of recession in the first in this intervention. In this intervention, this is the way I would think about management of the case. I do agree with you about the innervational based squam surgeries, but in this case, I would go more conservative with my main concern at the first intervention to correct the left hypertrophy and then judge the ptosis.
So you are planning to reoperate on her, Mustafa, right?
Yeah, I will go to it.
Good luck, but okay, if I'm in your shoes, the first thing is that I will explore the left medial rectus, because
Yes,
this limitation of adduction that I significantly increased it. I may expect to have some slippage on this in this medial rectus. So
Yeah.
if you are going to reoperate again, the first thing that you have to do is to explore this medial rectus.
Yes, of course. Yes.
You might find it slipped already. And this can explain the exotropy also in the primary.
Yes.
Is there any role for an MRI even before going to the exploration? Dr. Hiba and Dr. Ayman. Dr. Hiba, is there any role for the MRI?
MRI targeting the ocular muscles or the brain
Yes.
problem. As regard the brain problem, it's already an old insult, and for me, it's not an indication for to ask for MRI. For the ocular muscles, you might ask for the MRI and to find the muscle, the ocular muscles. But for me, if I'm gonna do an exploration, I would go for the exploration. I did not ask for MRI for any MRI for target the ocular muscles before the surgery.
Okay. Dr. Iyad Al-Sadoun is asking, Dr. Mustafa, do you have any details about the previous ptosis surgery that she
No.
did?
Actually, they did the surgery in somewhere else, and unfortunately, they don't have any reports or something like that. But from the shape of the scar, I guess it was elevator resection. I think, but I'm not
sure about the onset. I mean, you have pictures before the onset of trauma.
Before the onset of trauma, I asked the mother about that, and she didn't have, and she also didn't have any photos for her baby.
Okay.
Okay.
Do you have any more questions from the audience?
Yes. Dr. Fatima Ben Ragab is asking, was there any von Grafé sign?
Pseudo von Grafé sign. Pseudo von Grafé sign. White pseudo because when the eye is going down, the lid is not going down, but it's due to the short lid and the scarred tissues of the lid.
Yes, yes. Okay, Dr. Dina Hussam is asking, why would you consider offset of the horizontal to correct the left hypotropia?
I think you did so. I think you did already.
Why what?
Would you consider an offset of the horizontal to correct the left hypotropia?
I did it. I did it.
Yes, you did.
Yes. I shifted the tendons of the left eye up and shifted the tendons of the right eye down. And that's why the hypertropia is actually somehow corrected. It was 25 presbyopters left hypertropia in primary position, and now it's 15.
Okay.
Nice case and very nice case, yeah, Mustafa, and very nice way of thinking. You used to be a good fellow, and you are actually a good fellow, and I'm proud of you, and I'm proud of you all.
Thank you, Doctor. Thank you. Thank you so much.
Okay, I believe it's time to wrap up this session, and thank everybody for their patience and their attendance. Thank you very much, Dr. Hiba, for...
Thank you for you all.
Thank you, Dr. Ayman. Thank you very much, Dr. Ayman.
Yeah, thank you very much. I would like to thank you, Otar, actually, for this brilliant moderation. I'm very proud of you. Thank you for all the presenters. I'm really, you always, it's not something new for you. You always make us proud of you. And very interesting discussions, and I learned from this discussion. And I'd like to thank all the audience, actually, for the sharing. We have rich comments and questions from the audience. That's very interesting. And it was a very interesting way of interaction, and thank you very much. Thank you all, and I would like to remind all the audiences, please follow our page because we're going to announce for the coming events, inshallah. Thank you very much.
So
Thank you.
are there more events to come?
I usually enjoy discussing cases with you.
Will you announce about our next webinar in next
Thank you so much.
day? Tariq, would you please announce for our next webinar?
It's going to be
Round. Our next webinar with our international guest speakers. Will you please announce for it? Do you have the poster?
I'll have to look it up.
Okay, so what we have our next webinar next Saturday, 9:30 p.m. Cairo time. We will our webinar will be about the reoperation in strabismus. We actually intending to have many episodes about reoperation in strabismus, and we will start our first episode Saturday with our international guest speakers, Dr. Craig McEwen and Dr. Super Jane, and we would like you to join us in our first webinar. Thanks for all attendance, and we are very sorry for keeping you up late.
Thank you very much.
Thank you so much.
Thank you, everybody.
Thank you very much.
Have a good night.
Good night.
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 Thank you. Bye-bye.